Good afternoon, everybody. Thank you for joining us today. We're excited to host this conversation featuring Karen Henson, Vice President of Clinical and Ancillary Operations at Community Health Systems, in a discussion with Outset Medical's Chief Nursing Officer, Brittni McGill. As a reminder, this session will run for about 30 minutes, followed by time for a live Q&A. Feel free to submit questions at any time using the Q&A chat function at the bottom of your screen. We'll address as many questions as we can towards the end. With that, thank you all again for being here, and over to you, Brittni.
Thank you so much, Ariel. Good afternoon, everyone. And thank you so much, Karen, for joining us today. We really appreciate your time and your expertise. So, to get started, if you'll share a little bit about your organization with us.
Oh, yes. Thank you, Brittni. I'm glad to be here. Good afternoon, everyone. My name is Karen Henson. Again, I am the Corporate Vice President of Clinical Ancillary Operations for Community Health Systems. And Community Health Systems is one of the nation's leading healthcare providers, delivering care across 34 distinct markets across 13 states. We operate a little over 60 hospitals and roughly about 900 other sites of care, Brittni.
Excellent. If you want to share with our audience participants today a little bit about your background and also about your current role, because I know that it is relatively new and I find it very exciting.
It is exciting. So for those who have not met me, I have total of 30 years plus really of experience in healthcare, almost 26 of those as a registered nurse. I was very excited about this opportunity as there is some nursing departments in the clinical ancillary space, such as dialysis and wound care, but then there's also non-nursing clinical departments, therapies, RT, sleep centers, and so forth. And so I feel like my overall experience plus my nursing experience has helped me morph into this role. And really the decision, as Brittni said, this position is new for CHS. And so the decision to create the position really stemmed from a recognized need for dedicated leadership within these specific service areas. Historically, the clinical necessity of these departments is obviously understood. However, there was and has been a lack of data-driven analysts and analysis is going on regarding their broader impact on quality outcomes, such as infection prevention, hospital operations, an example such as length of stay, readmissions, and then, of course, resource allocation. So by moving beyond that uncritical acceptance of existing processes, we are working on integrations that will provide more data, just-in-time data, to analyze and quantify some significant opportunities for improvement that were really previously only assumed.
That's incredible because being a CNO myself in health systems, you're right, those ancillary departments are seen as support to the more typical or known service lines, and dialysis is and should be as equal to those others. And so I love that you talked about, a dialysis service line, and in your new role, you're creating just that from the corporate or enterprise level. And so I would love for you to share your vision for how you decided to stand that up and the structure you created to support it.
That's a really great question. And I would like to first say, of course, our vision for any service line is always to align directly with our corporate vision. And that's just to make healthcare exceptional for all involved, for all of our stakeholders, really. And so to achieve this, my primary focus really started out as standardization of care driven by evidence-based practices. And so I really started out focused on shared governance models, and this is where my nursing background kicked in, providing our hospitals and leadership teams with that data that, again, shared governance teams, such as we would call them our subject matter experts, really could walk hand in hand with us while analyzing some of the data that we're seeing, but then also helping us understand maybe what are we missing? What data do we need? What stories are not there that we're not getting a clear picture? And so then that whole my vision really at that time and at the beginning, and I'll explain why it's kind of shifting a little bit, was let's define some key performance indicators, which we need through established goals, consistent accountability, and we would ensure every facility would meet the quality of care standards. Ultimately, my goal was to partner and support our teams to optimize the resources that were at the facility level. I think as we talk today, what you're going to see is really my approach started as let's standardize this service line, this area of care. And now that the more that I've gotten into it and the more that I understand the importance of the, more of a, what I want to call a multi-site corporate view of this service line, truly as a corporate service line, is how do I make that reproducible? Right. And so it's creating a model, and we'll talk about standardization of care and operational efficiencies and, risk management, and now moving into strategic growth and culture. So really the vision is morphing the more that I learn, but it's been great thus far.
Mm-hmm. Well, that's the sign of a great leader is you are in tune to those changes because we are in a constantly changing industry, and you just have to be adaptable and amenable to changing with the industry. And so you mentioned key performance indicators and how you're leveraging data and analytics to align those things. Could you maybe share a little bit more about how you identified those things and how you are using the data and analytics you're getting from the Tablo machines and through Tablo Hub as a platform to help build those out?
It's really another great question, multi-layered question. So if I
Ah,
forget a piece of it, Brittany, just remind me. I think really when you and I even first met, we talked a little bit about, all I've been asking for since the day that we've met is data, data, data. And, you and I both agreed every number represents a person, an outcome, or an opportunity. And I believe that the truth is somewhere in the numbers. And I know that sometimes as clinicians, we get tired of hearing about the numbers. But what I was able to do is working with my Outset partners, and my internal quality team and my IT team and my subject matter experts again on the council. I was able to complete more of a comprehensive data review. And really, it was like looking at a performance evaluation of the service line. And those insights allowed us to establish a clearer vision, but defined goals. So those KPIs that you mentioned. And really, it was, again, the support of these partners, these internal and external stakeholders, and those conversations that, you knew when I came into this, and for everyone on the call, I've never been a dialysis nurse. So I needed to speak with Brittany and make sure that the data that I was looking at, how did it cross over for me to create a leading and a lagging indicator that truly aligned, and making sure that we were looking at the right thing and that I understood it first and foremost. And, when we looked at the evidence-based practices that, again, some of my internal and external partners have been able to share with us, we quickly saw a couple of things. The first things that come to my mind were how do we find these opportunities? Well, the facility leaders needed to have some access, and they needed to be and still need to be educated to their dialysis data and outcomes. How does it, what does that really mean? Ultrafiltration, how does that tie to CLABSI?
mhm.
And so, it goes back to my reply, I think, on, one of the first questions that you asked and that I get asked a lot is the why behind my role. And I think the largest opportunity was moving beyond that, again, that uncritical acceptance. If nobody's asking us about it, it's not a priority. And so it's more about they were focusing on basic things, staffing every day and things like that, which I say basic, which we know are not basic. But the analyzing of the data actually showed me that the teams didn't even know how to use the data, if
Mm,
that makes sense.
yeah. Getting the data is one thing, applying it is another, right?
Absolutely.
Yeah.
Absolutely. Yes. And so those key performance indicators, as I mentioned, one of them, the ultrafiltration and the collapsy. And then what it did is it drew us down further into let's audit all the collapsies. Let's look to see, are there some that are truly related to permanent dialysis catheters? Lo and behold, there were, which, again, brings forth a whole nother area of opportunity for us to continue to work on.
Mm-hmm. I had a mentor once that told me, and this has stuck with me for years, data drives change, change drives outcomes. And I think that's exactly what you and your council are doing across the enterprise. And so, you touched on ultrafiltration and its relation to CLABSI. Do you mind sharing your other two leading and lagging indicators?
So with our ultrafiltration, so our key performance indicator, of course, is ultrafiltration. Our lagging is CLABSI. That's more of our clinical quality performance indicator that we chose. We picked an operational KPI as well, and really what that leading and lagging indicator were disinfect percentage rate and productivity. If they, and that was in my mind, it clicked pretty quickly, but in others, it took a few minutes to understand. If you come in and the machine is not ready because the fail process happened, and they've got to come in and they've got to re-disinfect, and they all have a full day ahead of them. And so now we've got a machine or two that we have to redo. And we started looking at how many hours and minutes in every day, in a nurse's day, are they having to do a re-disinfect? What parts of those 3-tier disinfect processes are they struggling with the most, to help us be able to work with our Outset team, but then also to look internally at what we can do differently. And so that productivity metric really wasn't defined for us to go after and try to reduce resources. It was trying to alert the teams to how much additional time is being spent. So let's shore it up. Let's make the nurse's day go the way that it should be efficiently, their workflow process. And then our third and final one right now, key performance indicator, was really more financially driven. I'd hate to say that, but it's the truth, and it's the situation that we're in, and that's the treatment success. And so again, the lagging indicator for that one for us is our length of stay, avoidable delay time, all the way down to, okay, are we following the prescription? Did we get the result of the prescription? If not, why? Is there something we can do differently with either our Outset partner or internally that we can reduce that and maybe help that patient get out timely instead of having to possibly spend an additional day or two with us, the disinfecting not getting done, and then possibly leading to delay as well. So they all started to kind of, we started out thinking they were 3 separate things, and now they've all kind of morphed together, and we can see how each one, because again, a CLABSI is going to do what? Increase length of stay. So they all kind of go hand in hand once we started putting the puzzle together.
Mm-hmm. I love that you say partnership, because that's exactly what we did. Is we co-created what was important to you. Then we leveraged the data and analytics coming out of the Tablo consoles and through the Tablo Hub analytics platform, and we created this entire infrastructure to help you lead your newly launched council. And so I know you guys are probably about 6 months into this process now. Do you have, some lessons learned or outcomes or results that, this entire infrastructure has produced?
Yes. First, let me thank you for asking the question, because I wanted to take a minute or two to at least brag on the council. So the council, it currently consists of 5 subject matter experts from various levels of care, as far as their leadership roles. And we were very intentional of grabbing someone from each one of our regions. We have 3 regions that our hospitals operate out of. And I consult that council on nearly all of the decisions that are made. Sometimes I have to do a lot of explaining so that I can get them, the buy-in and as soon as they understand the clinical picture and the outcome, they're typically there. But, I found that it's vital for our frontline caregivers to own and drive their own clinical practices through the council. So they not only run our ongoing meetings with our dialysis leaders, but their primary focus, again, is standardization of workflows, so that they can improve efficiencies and create a safe environment for our dialysis patients and our caregivers. And so one of the things that we first started working on that I think a lot of people here can relate to is, imagine, 60 plus hospitals, imagine the policies, and no one's policy was the same. And yet the dialysis delivery is fairly streamlined. So they went to work quickly on reviewing policies, reviewing forms, and we actually had a pretty significant electronic health record downtime. I won't say the company, I don't want to do that, but we were offline for it was several days, as an entire corporation. And everybody had to go into downtime. We all know how painful that is, right? Downtime forms, writing everything. Well, guess what? Some of our newer nurses never charted on a written chart. So it was very painful for our local facilities. And we recognized quickly as we started asking for things, because there's a lot of work to go back through when you think of billing and charges and all of the things. And we had to go back through, and we were getting so much, it was just, there was nothing standardized. Everybody was giving us different answers for different things. So the council came together very quickly and have already standardized every downtime form we have across the entire corporation. So if something like that happens again, we have a cyber attack, anything like that, we're ready. It probably took them a month, and they got it. It's done, and we're getting ready to roll it out once it goes to the final approval process with our forms committee at the corporate level. So that was something that they did quickly. But then I want to go back to those key performance measures, because Brittni, as you remember, you were on site with us when we first started talking about it, and they were a little bit in their feelings about, hey, I don't control CLABSIs. People are messing with those lines, and it's not just the dialysis, and so we can't control it. Well, we started talking about the permanent line, excuse me, and we decided, let's start looking at it, and let's start looking at the risks around it. And so it was really interesting, because what should ideally be accessed by only a competency-supported dialysis nurse, the clinical reality is those lines are at risk of being accessed for other tests and treatment by other areas. Yes. And the frequent disconnects and reconnects also makes them highly susceptible to infection. But again, when you have people that are doing it that shouldn't really be doing it and don't know that they shouldn't be doing it, or there's not a standard policy driving to that prevention, we're increasing not only our infection, but mortality risk, again, operational risks with that. So now they're working on a prevention first approach to protect the access points of those lines, and are going to be putting together specific protocols. And that's some of the work that they're doing right now.
That's an excellent example. That is what true ownership looks like. You're able to dig deep, find the root cause, and then create a solution that is truly patient-centric. And by owning this service line top down all the way through, you have tremendous opportunity. I applaud you for owning it. There was a question in the chat about the correlation between CLABSI and UF. And, we had this discussion initially about, how those two things connected. And I think the way you see this is very interesting. So if you don't mind sharing that connection.
I'm sorry. I lost you for a second, Brittni. What was the last part of it? I'm so sorry.
You're fine. There was a question in the chat about the connection between CLABSI and UF. And you and I had a discussion about that connection. And I thought, the way that you see this is really interesting. So if you don't mind sharing, your thought process on that connection.
Absolutely. Well, again, it's so funny because I get asked the questions that, dialysis questions, especially, that I don't always know the answers to. And so I always reach out to Brittni. So first and foremost, everyone thank Brittni for helping me understand that the ultrafiltration percentage. And Brittni, I'm going to say, if I get it wrong, again, you can help me out a little bit on that part of it. But ultimately, when we first looked at the ultrafiltration rate, I wasn't understanding the process of how the Tablo machine works with during the treatment. And so we were like, okay, what can be some of that problem? And if I'm correct on this one, Brittni, the ultrafiltration, we talked about when there's like, there's could be things like water, the water control, correct? Am I saying that right? The way y'all say it,
So
water
we
control.
talked about, so first of all, giving our customers data on ultrafiltration comes from the ability to have those data and analytics pulled from the console. And so ultrafiltration is something that we track as one of our internal key performance indicators, because it's important to know that the accuracy of the treatment correlates to what is prescribed. And in Karen and I's conversation around ultrafiltration was that if you are not pulling the volumes as prescribed by the provider, you are going to have to access that line additional times. And every time you access a central line, it increases your risk of eclampsia. And so that is how we tied those two things together, which then spun off all of this collaborative discussion amongst the council with, how are our prescribing practices? Are they standard? Are we interrupting treatments unnecessarily because there are ancillary disruptions or potentially, patient disruptions in their status? And so there too had an entire talk track around what can we do better to make sure that we're not interrupting things or negatively exposing patients to undue harm.
Thank you. I'm sorry. I misunderstood the question.
You're
I think
fine.
when it was cutting out, I was like, I can talk about the filtration mechanism, but I'm probably not the best person to do that. But you hit it right. I mean, I couldn't have said it better myself. You can tell we've had lots of conversations about this. So I hope that did answer the question, because we have went back and we know we have opportunity when we started pulling. That's what led us to the treatment success KPI. Right. Is by asking that question, because of the original very first KPI I brought to Brittni and Satch was to the Outset team was the ultrafiltration, and then those conversations led us down to, and that's how we got the other two. So thank you for that.
You're welcome. I will say, having a health system CNO experience, I know how hard it can be to get information to help you lead. And that is something that I personally love about these consoles and this organization, is that we have line of sight to that. And that is an absolute differentiator, because I've been coining this phrase, without that level of detail, you're flying blind. It's really hard to lead if you don't have statistical significant evidence to drive your decisions as a leader. And they deserve to know the why. Do you mind sharing a little bit about what your leaders have shared with you about how they're using Tablo Hub on like a daily basis to run their operations at the site level?
Well, I mean, that's a really great question, because the Dialysis Council, as you and I have been talking, and we can share this here, we continue to have conversations about how to get more and more data flowing to and from. And some of the questions that came up during those conversations, I actually took back to the council, and I was asking them, how do you use it now? What would you like to see it do differently? If we could integrate, what would you like to see? And, I think that several of our leaders are using it now, especially to pull information so that they can see how they can better support their teams. Especially on their data, when they look at their day-to-days and they're doing more reviews. Quite frankly, before we started these conversations, they were not accessing the hub the way that they probably should have. And some of it is because I'm sure this is someone on the phone can probably, or call can probably relate to this. We didn't even have necessarily leaders in some of those spaces that even understood dialysis themselves. They were non-dialysis. But I mean, I think, in the day-to-day operations, our dialysis trained nurses, if I'm hearing you correctly, are using the Tablo machine itself, as far as their treatments. And I think I'm saying I think and we thought, but I'm going back to originally, the treatment success keeps coming up in my mind because they're putting in the prescription. And one of the things they said to us is, well, we can watch the prescription, we can watch the delivery, but then we also have to stop that treatment on and off so many times. So it may look like we're not delivering the treatment the way that it was prescribed, but then we step back and it's because the patient can tolerate it. But overall, I think there's more sensitivity to it. I really cannot tell you on a day-to-day basis every single thing that
Sure.
the hub has so much.
Yeah.
There's so much toolkit. I mean, there's so much resources in there. I know that our local facilities do utilize those resources that are in there, especially to help them from a regulatory perspective and driving, when they need something, where do we go to find the most accurate and up-to-date information for evidence-based practices and things like that. But I'm sure there's so much more, and I'm probably not. My counsel was here; they'd be saying, "Oh, there's so much more you could be saying." So
That's okay. That's all right. I get it. So when we first started this conversation, you talked about the breadth of CHS, so many sites across multiple states. How do you, from your corporate enterprise role, recommend to other corporate enterprise nursing leaders take on scale for a service line like this?
that's a good question. It's a powerful question. The word that comes to my mind when you first started asking that question is again, and I think I've said it once today, is reproducibility. I look at where you have the greatest success. I have, one facility that's actually a market that is exceptional, does very, very well. And that one, and as that leader, that market leader actually sits on our council, and there was a reason for that, right? Because the goal really should be for any service line is to replicate that model across the footprint of your company. And when I go about this and I look at service lines, I go to four things. I go to standardization of care operations. So, identical quality standards and clinical standards, and all the way down to patient education materials. Underneath standardization, I would say technology and even training. I didn't mention it, but we are creating all of our dialysis nursing. We're doing a whole orientation platform for them, and it will be standardized, and every dialysis nurse in our company will get the same exact training. That's a big lift. It will take us more than a year to get that done. But, outside of standardization, the second one is operational efficiency and structure. So centralized leadership. So again, I've got some market dialysis leaders, and I would like to look more at a dyad leadership model across campuses in the future. I think that that's where we're all going with a multitude of different service lines, addressing the logistics. The third thing I would say would be risk management and quality control. I mean, quality is the first flag for us as a company at CHS. Our new CEO and president made that very clear, that quality is our number one priority. I love that. It makes me feel good about coming to work every day. So that means performance monitoring, which hence our KPIs, and looking at our regulatory compliance, which we work with our Outset partners to help us in making sure that we are understanding what the compliance and regulations are for our dialysis centers. And then the last one would be strategic growth and culture, which, I really take a patient-centered focus on that. And, I think under that one, when I say culture, talent acquisition, I mean, we're all fishing in the same giant pond for top talent. And so if that's not a priority and we don't put that there, we're going to constantly be wondering why we're behind. Why are we struggling? Why do we feel like we have to start over every single time we get a new dialysis leader? So that would really be if I was having a cup of coffee and we were talking about service line development, that's where I would start.
Mm-hmm. I love that. And I think so many people on the call can absolutely relate to those things. Last question as we wrap up here. What would you like, dialysis leaders to take away? And I'm sure that since you've started this council, your team members have taught you some things that, they feel very passionate about as dialysis leaders. And so I think that's just kind of a great way to summarize for a takeaway.
Absolutely. First, let me just start with not that everything I've shared already is enough, right? You're probably like, yeah, yeah. I guess the basic starting point that I would want to share with you is be curious about the service that you have aligned and committed yourself with, because dialysis care is not just a delivery of a procedure, it is a service. And we have to start changing everyone's mentality and understanding on why it is a full service line. Never stop asking questions and follow processes at any level, anything that's going on. It may not even sound like it's dialysis. Follow it all the way back and trail it back to see all the way back to your service and what you're doing and what impact do you have on that? Because again, just like the ultrafiltration and collapsing, my council is so hyped right now on, we know how many we had for a year, that were truly permanent dialysis catheters, and they are absolutely determined to make it zero. They're on fire. What's that going to do overall for collapses? Great things. It's going to bring the rate down. Leapfrog scores are there. Pay for performance is there. I mean, it's something we all have to talk about. But you may not realize unless you just ask questions and you're just curious about your space. The other thing I would say is don't accept the national average is blank, and so therefore that's what it should be. One of our KPIs is above what the standard is. I set that goal for 98%, and it's tied to my compensation. So I believe in it because I believe that we should be striving for excellence. 100% should be on everything, even though we're human and things happen. If we're not striving for 100% and striving for excellence, we're never going to gain it. We're never going to get there. At the end of the day, that patient is worth it. That patient
Yeah.
belongs to someone, right? So that patient is worth excellence.
I love that. So I wrote down, the patient deserves for the status quo to be challenged and for the caregivers to have a spirit of inquiry to achieve that excellence. That's fantastic. Thank you so much, Karen, for your time. We so appreciate you and your leadership. And we hope you all have a great rest of your day. Thank you so much.
Thank you. Bye-bye.